Okay, good morning. My name is Christine Denny, and I'm one of the co-directors of Grand Rounds, along with Doctors Kate Elkington and Jeff Miller. Dr. Kate Elkington will join me today in co-moderating this Grand Rounds, and we have a few announcements before we begin today. Next week's Grand Rounds will be given by Dr. Cheryl Corcoran, Associate Professor of Psychiatry, the Program Leader in Psychosis Risk at the Icahn School of Medicine at Mount Sinai. The title of her talk is Computational Phenotyping of Communication Behavior in Psychosis and Other Neuropsychiatric Disorders. This will be an in-person Grand Rounds with an additional Zoom option. For those attending next week's session in person, lunch will be served after Grand Rounds in the multipurpose room on the 6th floor. For today's Grand Rounds, I want to encourage everyone to ask questions or post questions at any time during the talk using the Q&A feature at the bottom of the Zoom window. This is separate from the chat. Please do not use the chat. If you are a trainee, please put the word trainee before your question, as we will prioritize trainee questions. We encourage attendees to ask questions themselves on Zoom. Kate can temporarily promote you to panelist. Please also write "can ask question myself" or "prefer to have my question read" at the end of your question. Finally, for today, if you are attending in person, there will be a lunch after Grand Rounds in the multipurpose room on the 6th floor. Now, for today's speaker. Dr. Talati completed his PhD in neuropharmacology at Cornell University, Weill Medical College, and his postdoctoral training here at Columbia University and the New York State Psychiatric Institute. He's looking at me very scared of what I'm going to say right now, but it's all good, I promise. He is currently an associate professor of clinical neurobiology in the Division of Translational Epidemiology here at Columbia, and also one of our new incoming co-directors of Grand Rounds. So I feel like you will be in really, really good hands when we leave in January. As both a neuroscientist and psychiatric epidemiologist by training, Dr. Talati's research uses population data and birth cohorts to study the intergenerational transmission of depression, with a particular focus on the long-term effects of maternal depression and antidepressant exposures in pregnancy. He is currently a principal investigator on several multi-center R01s from the NIMH, NIDK, that address the long-term effects of brain and behavioral development among offspring who were exposed to maternal depression or antidepressant medications during pregnancy. In addition, Dr. Talati has been funded by NIDA, the Brain and Behavior Research Foundation, American Foundation for Suicide Prevention, where he currently serves on the Scientific Advisory Board. He has also received numerous awards from ACMP and the Organization for Human Brain Mapping. He is an active teacher and a mentor in our department and has over 80 peer-reviewed manuscripts in excellent journals, including JAMA Psychiatry, Biological Psychiatry, too many to name. On a personal note, I met Adi many years ago when we actually gave Hot Topics Grand Rounds together. And since then, we have become dear friends, hanging out with Randy and Chris Anaker, who's here today. And he is just an absolute joy and pleasure to be around with. So it is a real honor and a privilege to introduce you today. And I'm so proud of you. And with that, the title of his talk is Prenatal Exposures to Maternal Depression and Antidepressant Medications, Pieces of a Complex Puzzle. So take it away.
Thank you so much, Christine. Can everyone hear me? Thank you for that very, very kind introduction and for inviting me to speak and for providing evidence that I do have friends here at Columbia. I'm very happy. And I could say the same about you. It's been such a joy. And thanks everyone for coming in person. Now, the main theme of my work, as Christine alluded to, was examining the intergenerational transmission of depression in families, which shouldn't really be a surprise given that my primary mentor is Myrna Weissman. But today I'm going to focus on one piece of that, and that is the intergenerational transmission during pregnancy, which is a very unique window if you come to think of it, because it's the only time that the two generations are physically locked for close to 9 months. So there are a lot of opportunities for risk, but also reward. Yeah? So I'm going to be presenting some data from studies already published and some that are currently ongoing. And my goal is both to present the findings, obviously, but also to show a model of translational epidemiology where you could go from preclinical work to clinical work to population studies and back to sort of jigsaw puzzle different pieces of hypotheses together to understand mechanisms. I don't have any disclosures of any kind. Now, usually when I give a talk to a non-psychiatric audience, I start with a section on what is depression, why is depression deserving of being treated, why is parental depression bad for the offspring, et cetera, et cetera. But I certainly don't need to belabor that here. So instead, what I'm going to do is turn the story around and start from the preclinical story, which is actually how I got involved in this line of research to begin with. And it all started with work by Jay Gingrich and Mark Ansauger, both sitting here in this audience, showing what they identified as a serotonin paradox as follows. And the paradox was as follows. If you give an antidepressant medication to a mouse in adulthood, you see reduction in depression, anxiety, stress-like behaviors, as you would expect, given that it's an antidepressant. But if you give that identical medication during gestation, you see a flip. You see the opposite effect, which is an increase in several depression and anxiety-like behaviors, right? But that's not all. When they delved into this further, they found that these risks were specific to antidepressants that had a serotonergic mechanism of action. If there wasn't a serotonergic action, they didn't seem the same effects. Moreover, and this is important, the findings didn't emerge when the mice were born, but they emerged around when the mice hit periadolescence, once the brain circuits had a chance to mature. And finally, it wasn't just behavioral abnormalities. They also saw a number of biological alterations, including changes in arborization, firing frequency, neuronal density, in regions of the limbic cortex and the hippocampus, which are involved in emotion. Now, what is the rationale for this paradox? Well, it turns out in adulthood, we know serotonin is a potent neurotransmitter, but in gestation, it also acts as a growth factor. So it's involved in neuronal growth, differentiation, synaptogenesis, et cetera, et cetera. And the serotonin transporter, which is the protein that the antidepressants bind to, is located not just on the serotonin neurons, but also during pregnancy on a number of non-serotonergic systems. And this is just an example of work done by Patricia Gaspar's group showing in mice the ectopic representation of the serotonin transporter through pregnancy, which extends far beyond just the raphe or other serotonin neurons. So the point of all this being that any gestational changes to serotonin have a much wider imprint of potential action than they would have in the corresponding adult period. Now, already a question should be churning in your mind. Are these relevant to human populations, right? And this is important because we know that antidepressant use in pregnancy has increased in recent years, and I'll show you some data momentarily. We also know that antidepressants, most of the first line of antidepressants, invoke a serotonin mechanism. And we also know that they all cross the placenta into the fetal compartment. So the opportunities for risk are there. However, in an animal model, we have the good fortune that the opposite of giving an antidepressant is simply not giving an antidepressant. But in the real functional human world, when warranted, the opposite of giving an antidepressant would presumably mean leaving the depression untreated. And we know from a whole host of studies that that itself has impact on the fetus. There's a number of prenatal changes such as hypertension, inflammation, HPA reactivity that can affect fetal development, but also increase the chance for maternal postnatal depression, which has another whole range of adverse outcomes on the front. So the question really needs to be recalibrated, not from are there any developmental effects of antidepressant exposure, but rather are any effects of antidepressant exposure different, and how do they weigh compared to the alternative risks of exposure to maternal depression alone? That's really the clinically relevant question. To begin to test this question, Jay Gingrich and Myrna Weissman and a bunch of other collaborators in this room had a Conti Center. And what they did is they used Finnish population data that I'm also going to talk about a little later, to generate these cohorts of exposures and outcomes. And what they showed was very interesting. They followed offspring until age 14 on the x-axis, and they looked at the rates of depression emergence, which is on the y-axis. And for depression, they note that if you were exposed to an antidepressant in utero, an SSRI in particular, the rates of depression in the offspring were far higher than offspring who were either completely unexposed in black, exposed to maternal depression in blue, or whose mothers had taken an SSRI but quit sometime prior to pregnancy. They didn't quite see the same surge for anxiety disorders. But this work then fielded a number of follow-up questions. Number one, what happens after age 14, right? Is the pink bar, is the increase just continuing and continuing? Is it normalizing? Or are the other groups catching up, essentially negating the difference? Moreover, what's unclear is how much of this exposure is attributed to medication effects versus underlying depression effects. And finally, we're talking about age 14, but they're 14 years before age 14, well, obviously. And what are the neurodevelopmental mechanisms and the antecedents of these exposures? So this is where I became more involved in the story. And what I'm going to talk about today are three sets of studies to test essentially the effects of prenatal depression and antidepressant exposures on offspring development across childhood. Now, I'm going to use the word I because I'm the one presenting, but this is really, really a collaborative effort across probably half the people in this room are involved in some degree or the other. So my population studies, I'm going to focus primarily on the sister cohort of the Finnish data, which is Danish National Population Registries, and I'm going to supplement it with some US data as well at times. For the neurodevelopmental studies, I'm going to focus on a birth cohort that Jonathan Posner, Larissa Taxa, and I set up in Sherbrooke, Canada. And please take a moment to enjoy the acronym. And then I'm going to talk about the clinical implications. And I'll leave the clinical implications to the end, but I did want to give a primer that I'm going to be giving you lots of data with huge sample sizes and nice odds ratios and p-values and hopefully impress you. But at the same time, I also want to caution that, odds ratios and p-values are not people. And you could have a sample of million, but what really in the clinic matters is the N of 1. And every case is unique, every situation is unique. So it's very tempting, but also important to not use research data like these to jump to clinical conclusions. And we'll come back to this point on the last slide. So let's start with the Danish National Registers. Why did I choose Denmark? One thing about all the Scandinavian countries that is really great for longitudinal research is that healthcare is number one, free, and number two, centralized. What this means is healthcare information is collected in different registries. So it's birth registries, medical registries, prescription registries, psychiatric registries, et cetera, et cetera. And you could merge across these different registries to get cohorts of interest. And this is unlike in the United States, where your presence in a system is entirely dependent on your health insurance status. So for example, if you're lost from the system, you don't know if you had a bad outcome, you had a good outcome, or you changed health insurance plans. This is our Danish team who's been involved in the study, especially the people highlighted. They're all very tall, Danes, yes. Even the non-tall people there are tall, so it's a lot. And this is a slide that my colleague, Anton Pottegard, likes to show. It's the Danish registry system nicely and merrily sailing along the sea of epidemiology doing their wonderful research. And there are two new researches that I think this audience might be interested in. One is the vaccination registries, which have a huge amount of data on COVID and the effects of COVID on mental health. So that's something people might be interested in collaborating with us. And the other one is education registers, which include both academic performance, school dropouts, school attendance. So for those who have a more child focus, who want to extend beyond simply diagnoses into these more real world outcomes, there are lots of opportunities here. Now, as with everything, not all the registers emerged at the same time, but by the mid-90s, you could see that most of the key registers were both online and they were in electronic format, which perfectly coincides with the growing rates of antidepressant use across the world, SSRI use. So this is a graph that shows, this is Denmark specific, but it's fairly similar in other countries. The top blue line shows that there's a monotonic increase in the use of antidepressants across the 90s, till about 2010. Then it falls a little and flatlines. What you also see is that almost all of that is accounted for by SSRIs, right? The brown line under it. So you could almost use these two terms interchangeably. For those who would like details, this is the breakdown of the individual SSRIs, with sertraline and citalopram dominating the prescriptions. So what we did, this is our primary study design. We used the Danish cohorts to generate study groups of interest. We excluded people who met our exclusion criteria, like multiple pregnancies, missing data, or not live-born. And then for a first pass, we created two very global groups. The children who were exposed to at least some SSRI during pregnancy, right? So at least one prescription on the mother. And then the opposite, those who were not exposed to any pregnancy. And for now, we took out a third bucket of kids, which were the children of mothers who had used an SSRI prior to pregnancy, but then stopped taking them before becoming pregnant. And we used different time windows to justify that third group. Now, you could obviously imagine that the users, the SSRI exposed and the unexposed group, are going to differ on many, many demographic and clinical characteristics. So we used an approach called propensity score weighting to account for these. And to just give you a brief summary, propensity scores, which are also called quasi-experimental methods, are ways to balance two groups that are not necessarily similar to each other by weighting or matching on characteristics that might predict whether you were going to fall into one group or another. So just an example, if you were an SSRI user and you had a number of emergency department visits, you would only be included in the sample if there was a non-SSRI user who also had that many number of emergency. So you're equalizing on the covariates. In a weighting case, you're doing the same thing, but you're not excluding those where there's no match, but you're weighing up or weighing down to make the samples as similar as possible. So we use both weighting and matching. I'm going to show you the data primarily with weighting because the sample is bigger. You obviously lose a lot more people with matching, but the findings were pretty equivalent. So this possibly scary slide shows the difference between the two groups at the start of the study. And you could see the higher the bar, the greater the difference in the variable we're looking at. So you could, and 0.1 is sort of considered the acceptable level of variation. So you could see up front, age is not that different, parity is not that different, weight is ish different, but then smoking is different, right? And the socioeconomic indicators, we have quite a few of them that are different. So we used our weighting techniques and then reanalyzed these differences. And what you see is we were able to get rid of, or at least minimize most of them. Now, this is an important point because we've tried to do similar things in US-based cohorts and we're simply not able to. And the reason is that there's such a strong socioeconomic gradient in who gets healthcare, the quality of healthcare, the affordability of healthcare, that no matter how hard you try, you're going to have more residual differences. We did the same for clinical differences. And here you see a less clean pattern. We were able to control for GP visit, outpatient visit, hospital admission, but psychiatric visits were not, we could not fully control for. So there's going to be some remaining confounding, which makes sense, right? If you're on a medication, probably more likely to be going to a specialist for that. This is just sort of a model to show you the type of ways we used to calibrate the groups. So now let's turn our attention to the offspring. What were we interested in studying? Well, we chose as our primary groups, based on previous work by Jay and then other people, depressive disorders as a class, anxiety disorders as a class. We also chose antidepressant medications because those can often be a proxy for the disorders and often have better notation in the medical records, because for depression, you may not necessarily note it, but a prescription for an antidepressant is more unambiguous. We also included adjustment disorders. I don't know why, but we did. So what I'm going to show you now is 4 groups of outcomes. I'll first show you this sort of omnibus anything goes outcome. Then I'll show the individual diagnoses and medication outcomes. And then in the third part, then I'll show you the modeling that we did. So here is a very crude or broad description of any outcome in the first 14 years. And you see a generally similar pattern as what we saw in the finished data, where the 2 lines begin to peel off at around 10. And you see by age 14 that there's an increase in the exposed group compared to the unexposed group. This is after controlling for maternal depression and all the covariates I aforementioned. What happens after? So we continued following them up till age 22, and this is what you see. So there's an increase in both groups. That needs to be acknowledged, right? Excuse me. Yeah. Oh, you can't see what I'm seeing. Oops. Simon, I think oh, he fixed it. So you see that the odds ratio is 1.56. Now you may be thinking that's not a very impressive odds ratio, especially for grand rounds. But it is what it is. But let me remind you that these are common disorders, right? So SSRI use is not uncommon and depression is common. So in these sort of situations, even if you have a small relative effect, when you look at the actual numbers, you could have a fairly significant number of children who are either at additional risk or benefiting. So now let's break this down into its individual components. We looked at depressive, anxiety, and adjustment disorders. And if you see, the age is at the bottom, and the black lines are the unexposed, and the dashed lines are the exposed. And you see in each case that there's a rise around 10, and it gets a little bigger with time. So it's that interesting. We looked at the same thing with medications, and we saw that the biggest effects were for SSRIs, where you see more than a 2-fold increase in the offspring getting an antidepressant if the mom got an antidepressant during pregnancy. Now remember, this is controlling for maternal depression and covariates. Now, everything I've shown you thus far is only for initiation, right? So did you ever get? But one could also hypothesize that the course of depression or the course of medication may be different in the exposed versus the unexposed. And here again, we were guided by wonderful data from Jay Gingrich and Mark Ansorga, who had suggested that if you are primed by SSRI exposure in utero and your brain circuits are primed accordingly, you then become more resistant to later antidepressant treatment, sort of like a treatment-resistant phenotype. So what we did is, remember, everyone's first prescription is here. So we took the subset of people who had a first prescription, and then we followed their subsequent prescription out for 1 year. So in Denmark, prescriptions are typically given in 90-day windows. So four refills is about a year. We first did this for the unexposed group. And 2 things should hit you immediately. The SSRI group is infinitely larger than the other groups, which makes sense given the prevalence of use. And then the second thing you should see is that there's a drop, which is not, again, surprising because not everyone who gets an initial prescription is going to refill it. Some may get better, some may have tolerability issues, and this is not uncommon, right? We then hypothesized based on the animal data that if prenatal exposure was conferring a treatment-resistant phenotype, one of 2 things should happen. Either these first set of bars should not drop, right, which means that the people are getting refills at higher rates, Or they may drop, but the other groups increase, which would suggest that they're switching to a different antidepressant, and switch to a different antidepressant, especially in teenage years, is often used as a marker of treatment resistance. Okay? But we didn't find that. We found that the two rates were pretty similar across the exposed and the unexposed group, suggesting that there isn't sort of a prenatal priming effect that is contributing to this treatment increase. So in the next set of analysis, we're going to try and put all this together. Water. So in all the graphs I'm going to show you for the next several slides, I'm showing you hazard ratios, which is a kind of odds ratio that accounts for length of time in the system. And a hazard ratio of 1 means there's no effect. The two groups are equal. Once you go above 1, it becomes a risk factor. And once you go below 1, it's a protective factor. And we do have some protective factors as well. And this is the sample size that we're dealing with. So this is essentially a condensation of the first graph I showed you. You see there's about a 1.44 increase if you were exposed to SSRIs compared to not exposed after controlling for all the variates and doing the propensity score weighting. We looked at it separately by gender, and we found statistically there are no differences, but the trend was for higher rates, higher effect sizes in the boys. And we looked at this further and checked it out, and it's really driven not by there actually being an effect greater in the boys, but rather that the baseline rates at that age are lower, because peri-adolescent depression is so much more common in girls that it's almost like you're closer to the ceiling to begin with, but in the boys, you're lower and therefore have more space to rise. And I'll show you data later on if there's time. We also looked by trimester, and we didn't really see a statistically significant effect. Now, SSRIs are antidepressants, but they could also be used for other disorders, right? They're not just anxiety, but sometimes for sleep, occasionally for gut disturbances. So it's possible that these could be driven by these other non-depressive disorders. So we created a subset of moms who had a formal diagnosis of MDD within the 9 months of pregnancy. And then we looked at the additive effect of SSRI exposure. And you see the result, the effect is a little smaller, but it's still there. Okay? Now the findings get more complicated. What we looked at next was comparing the antidepressant exposed to the moms who had stopped taking antidepressants prior to pregnancy, with the rationale that a lot of the factors that would determine whether or not you got antidepressant in the first place would be present in both groups. And here, for the first time, we see a significant reduction in the hazard ratio. It's still significant, but if you compare it with our original, you see about half the effect that we were attributing to the antidepressant effect appears to still be there, but the other half has sort of got sapped away by this comparison, suggesting that some form of maternal depression severity is accounting for this effect. We also tried to do a few additional analyses with the following rationale. If the SSRI is having an effect that's purely driven by in utero mechanisms, what you should see on the left column is that maternal prenatal use should increase that effect, but maternal postnatal use in the absence of prenatal use really shouldn't, right? Compared to depression, untreated depression. And similar, the father's use during the index pregnancy certainly shouldn't. So these are called negative controls because they're very similarly designed, but with the purpose of not finding the effect, right? Because it's physically impossible if the in utero mechanism is in play. If, on the other hand, the antidepressant is not indexing an in utero mechanism, but is a marker either for more severe depression or for family risk, because we know from Myrna Weissman's work and others that depression runs in families, and the children who eventually will get depression may be at higher risk by parental psychopathology. And when we did this, we found mixed results, but we did find significant effects with both postnatal SSRI use, but also maternal postnatal use and father's SSRI use. Now, father's SSRI use cannot be operating through intrauterine mechanisms, right? We excluded the moms who had taken an SSRI. So this would tell us that at least some of the effect that we are seeing is related to family risk factors. And then in the final part of this model, what we try to do is put everything together. So we put the solo use, mom only, mom postnatal only, dad only, and then every possible combination of the other. And what you see, these are now crude findings, you see that moms' prenatal and postnatal exposures have almost the same effect. The dad's effect is much smaller, but as you pile on more and more exposures into the model, the risk increases. This is in the crude because I wanted to magnify the findings, but this is the actual final finding. And what this tells us is that we're not excluding the possibility of biological effects, but what we're saying is that in the effects reported, a good chunk of them are likely being driven by either maternal depression severity or by common familial factors that might contribute to the mom or the father having depression. Now, you'll notice that everything I've talked about right now is about the brain, right? Psychiatric disorders, psychiatric treatments, but the body doesn't end at the neck and nor does serotonin. So we said, well, if SSRI, antidepressant exposure, is affecting the brain, wouldn't it then also affect the gut? Because 95% of the body's serotonin actually is in the gut. And the serotonin transporter to which they bind, the same proteins that are present in the brain are also present in the gut. Here, also, we allowed ourselves to be guided by animal models, and especially by work by my dear colleague, Cara Gross-Margolis, who was at Columbia University and is now at NYU. And people always ask me this question. She's not related to Amy. Still isn't. No, okay, still isn't. So what she found that if you alter the serotonergic system, either via manipulating the transporter or by directly giving fluoxetine, you affect gut function. And I'll briefly go over these. So genetically manipulating the serotonin transporter increased the total GI transit time, right? It didn't affect gastric emptying, but it significantly increased colonic transit. And here in the middle figure, you see a visual representation of the changes in peristaltic contractions resulting from this. More impressively, she showed that if you give fluoxetine, which is an SSRI, during gestation, you also significantly increase the colonic transit time, and this could be reversed by a serotonergic 5H4 antagonist. So this, of course, got us thinking, does this apply to human populations? Now, unlike with the mental health outcomes, there's been very, very little on gut outcomes, and the two studies we've sort of found is one study showed that SSRI exposure was related with greater laxative use, but not antidiarrheal use, so sort of suggesting a constipation phenotype similar to the delayed colonic motility found by Cara. And another study showed that prenatal antidepressant exposures increased the complaints of GI problems in children. But there were a number of limitations in terms of, the typical small sample size, et cetera, but none of these studies had rigorously controlled for either parental psychiatric or gastrointestinal disorders. So we said, let us look at this. And we used as our primary outcome a class of disorders called the functional gastrointestinal disorders. And these are disorders considered a brain-gut interaction that cause pain and discomfort, but in the absence of any documental structural physiology. So if you have surgery, or if you have congenital abnormalities, or you have Hirschsprung, by definition, you cannot have an FGID. They're common in adults and children, and several risk factors like diet, maternal depression have been identified, but the etiology remains unclear. And they also co-aggregate with psychiatric disorders in adulthood. The classic example is IBS and anxiety, right? But what's most interesting is that many of the same antidepressants that we use to treat depression and anxiety are often also used to treat the gut disturbances, and also are not equally effective in everyone. So this raised the question, are we having another serotonin paradox where the very same treatments that are used to rescue a phenotype in adulthood might be contributing to that same phenotype in child? So this is a study design that I already went through, but we applied it for the gut function. And this time, given that we saw our findings with the discontinuers, we used our exposed SSRI group as our primary group, but we used the discontinuing group as our primary comparison group. So it's a more conservative analysis, okay? And I'm going to show you the offspring outcomes till age 15 after I top up. So this slide is sort of a gestalt slide that shows the likelihood of getting any functional gastrointestinal disorder in childhood. So it starts at birth, and you see that there's a modest increase that continues till age 15, sorry. The hazard ratio is 1.08, again, not particularly impressive. We then go into the individual class of disorders. For functional nausea and vomiting, we see absolutely nothing. For functional abdominal pain, we didn't see anything, but the findings almost seem to go the other way, where the antidepressant exposure protects the offspring. I have no real explanation for that. But then when we looked at functional constipation, voila, you get a very clear separation of the groups that continues through childhood, okay? Now, these findings, we did a number of sensitivity analyses to check the robustness of the finding. So this is your overall outcome. We looked at it by both physician diagnosis and laxative prescription, because in Denmark, you typically only get a laxative prescription you only get a laxative through a prescription. You don't get it over the counter. You can, but it's rare. So the findings were consistent. What is also interesting is that the incidence windows were consistent across the study period. And I wanted to point out and clarify, this does not mean that they started in the first year of life and then stabilized. What it means is that in each 5-year window, there was a new group of individuals who also were at increased risk and started getting the disorder. So it's not unlike depression or anxiety, where some of the risk factors may be predisposed to either in utero or in early development, but how that then translates and manifests into a clinical form might depend on your life experience, in this case, your diet, exposures, environment, et cetera, But the point being that the risk continues unabated till 15 years, and 15 years is when we stop the follow-up. So it doesn't mean necessarily that it wouldn't go further. We also did some additional sensitivity analysis to show that this is a chronic phenotype, because even when you require multiple diagnoses from the same individual, in this case more than 3, you still see the finding. And this time when we looked at the DADS use, there was a very slight effect, but it was not anywhere nearly as significant. So let me wrap up this first portion of the talk by giving you an interim summary. So for the brain findings, we see that the findings are translated on their face from the preclinical to the clinical, right? We do see increase in depression and anxiety and adjustment disorders. We see also that they're earlier. That's another key point in terms of surveillance. They start around age 10, and then they continue all the way through age 22. Now, we cannot rule out causal effects, and there probably are some, but at least a significant portion of that is due to maternal depression. So what do you make of those findings in terms of public health implication? Well, regardless of the mechanism, the exposed offspring are still a high-risk group, and they could benefit earlier pediatric screening. And as I mentioned before, the effect sizes are not large, but the disorders are so prevalent that the actual numbers can be meaningful. Now, when we translate to the gut findings, we see a similar but slightly nuanced version. We also see higher rates of gastrointestinal disorders, but they're almost exclusively driven by functional constipation. Unlike the mental health disorders, these appear solidly in the first year of life and then continue all the way till age 15. we can never, these are observational studies, they're not randomized studies, so we can never, ever rule out residual confounding. But in this case, there is a little bit more evidence that the findings are likely to be attributed to the SSRI exposure and not by maternal depression. And the public health implications are really the same, that it doesn't matter if you're a clinician what the micromechanisms are. If a child is exposed, they might be at increased risk for these disorders. Now, in the second part of the talk, yeah, I'm aware of time, thank you. I'm getting dirty eyes. But you're still one of my favorite people. So in the second part of the neurodevelopment study, I thought rather than give a long-winded history of all the studies and the risks and the pros and the cons, I'm going to give a recent example because I think it really represents the field well. And this is a study that was just published a few weeks ago, and it's the Generation R study that looked at the effects of SSRI exposure on an offspring brain development across 2 time points in childhood. And it was published in JAMA just a few weeks ago, and I had the good fortune to write the editorial for it. And what they found was as follows. When they looked at different exposure groups, so prenatal SSRI exposure is this gray, sort of bluey gray bar at the bottom. And when you first look at it, the groups are very different, right? They are lower in terms of gray matter, white matter, amygdala volume, and hippocampal volume. So there's certainly something going on. And when they looked at it further, excuse me, but one thing I want to say is that what the gray matter consistently was different across time, but the white matter, the hippocampus and the amygdala largely normalized across the study time. So the authors hypothesized or posited that cerebral gray matter is a risk outcome following SSRI exposure. And it was a very good study. But when you look at the weeds of the study, a few things became emergent. Firstly, they had almost, in fact, more than 3,000 people in the sample, but only 41 prenatally exposed. I mean, it is what it is, but that's a very low number. Also, 25% of that population was also using benzodiazepines, suggesting that the SSRI exposure may be partly confounded, but also that it's not your garden variety depression, but either a more anxiety comorbid depression or some other depression that's requiring this further medication. And also, the depression exposure was measured by essentially one variable. I'm going to skip over the ABCD example because Milena might present it. So current limitations of the field are that the studies have had limited follow-up, and in many cases, the exposure and the outcome is being reported by the same person. But the biggest limitation, in my opinion, is that we have all these hyper-sophisticated imaging methodologies, and processing pipelines to look at the brain with excruciatingly detailed views. And then we collapse the whole of our exposure variable into, have you ever been depressed? So, right, there's like an asymmetry in the level of detail here, and we might be losing a lot of the clinical picture by using such a macro level variable. And the other question is, it's one thing to find neuroimaging differences, but if they're not really stable and or related to further clinical dysfunction, how relevant are they really, right? There's a lot of variation in the brain that means close to nothing. So it was with that view, largely to better classify the course of depression in pregnancy, that cannot be done through these population studies, that Jonathan Posner, Larissa Tessa, and I started a new birth cohort in Sherbrooke, Canada, called the Myrna study. And what we did is, we recruited women in the first trimester of pregnancy instead of at the end, and we assessed them on PHQ symptoms, for depression, anxiety, stress, monthly through pregnancy. And then during the COVID period, we added questions on COVID. And towards the end of the pregnancy, we did a full skid, sort of to get a more formal conceptualization of the diagnosis. Now, depression doesn't end when the baby is born, obviously. So we continued measuring them, the same symptoms monthly for the course of the study period. And what we did that was different from other studies is instead of doing our final classifications when we recruited the mothers, we waited till the end of pregnancy, and then we sort of finally classified the mothers group, because some women will start an SSRI after they were pregnant or will not have depression when they started off, but then develop depression. Once the babies were born, we did an MRI and an EEG scan at 2 to 4 weeks. And then we did a series of sort of behavioral assessments during the 2 years. And some of these were impacted by COVID, others not. And then our sort of gold standard is the Baileys and Bitsies at age 2. Now remember, the body doesn't stop at the neck. So we wanted to look at the gut outcomes too. Oh, I'm going the wrong way. So we got a second grant where we looked at biospecimens, and we collected maternal blood and maternal stools right during pregnancy, one for each trimester. And then we looked at the placenta and the cord blood at delivery. And then we continued examining the child's gastrointestinal symptoms and the mother's in the period following the baby's birth. Now, I'm going to focus in the remaining time largely on the prenatal side, because that's what sort of fits with the flavor of the talk. But I will give you a little bit of a little peek into the Bailey's data at 24 months, since that was our primary outcome. The MRI was the portion that was most impacted by COVID. So we're still working on the data. But even though the MRI was closed, the baby is still pooped. So we continued, and we have a lot of clinical data that I'm going to present to you today. Oh yeah, and our ultimate goal, represented by this wiggly arrow, is to really not just look at neurodevelopment and gastroneurodevelopment, but see how these intertwine. Because in adulthood, we know that they're related. So can we identify early phenotypes that might predict who is at risk for, psychiatric disorders, who is at risk for functional GI disorders, and if there's a group that might be at risk for both. So the first thing we noticed, it's messy. So the top row shows the PHQ symptoms, which is essentially a depression score for the moms in the 3 groups. And I apologize, the color schemes are very illogical across the graphs. So healthy control is green on the top, depression is blue, and then the SSRI is red. And I purposely didn't put any p-values or statistics here, because we don't really need them to see that the group difference within group difference is far more than the across group difference, which is saying already that just having this dichotomous variable probably isn't going to be enough, right? We saw the same thing, in fact, even more for the anxiety. So these are from recruitment to the 9 months of pregnancy. That's the y-axis. I'm sorry, the x-axis. And the PHQ scores and the anxiety scores are your respective y-axis. So there's a lot of variation. So then we asked the question, if our groups are really creating so much heterogeneity, can we let the data themselves tell us how these people are separating, right? And whether there's another way of classifying them. So we used data modeling and came up with the best model that fit the data was a 3-class model. And it was as follows. There was one group of mothers, of women, who were sort of consistently low across pregnancy. And this was more than half the sample, which is good, right, from a clinical point of view. So the symptoms varied, but they were identified by persistently low PHQ. And then there were 2 other groups that were generally similar, but one started off a little lower, became worse, very marginally, and then got better, and a third that got consistently better. However, our initial groupings did not fully align with these. And by that I mean, so if you look at class 1, which is the green class, see, I told you my colors were all off. The green class, most of them were healthy controls, as you would expect, but you do have a smattering of people with depression and SSRIs. But once you look at the other 2 groups, they're almost equally distributed. Right? And that's probably because some women who have depression get better without treatment. Other people who are on treatment don't get better. So it's really a mishmash of things. And the take-home message from this is that simple dichotomous grouping is unlikely to realistically account for the time-varying course of pregnancy. All right, so what I'm going to show you is like a very brief set of data at 24 months. And this is preliminary, so it could change as we do more. But what you essentially see is we looked at the Bayley's language, cognition, and motor standardized scores. So 100 means you're sort of at the population norm. And for cognition, which was our primary outcome, you don't really see, well, you see no statistical difference. You might see like a little bit of a dent in the two depressed groups. So the pink is the depression with no treatment, and the red is the depression with SSRI treatment. But the most important thing is that the SSRI group is not doing worse, right? So the children who are being treated are not having, the mothers who are being treated are not having the children with the worst outcome. You see a similar general pattern for motor, but again, the SSRI is not worse. For language, and this is, again, I must say preliminary, but you see that the depression group is worse, but the SSRI group is completely rescuing the phenotype. Is it because the mothers are doing better and therefore engaging more with their children? We don't yet know. All right. Now, the gut component of the story has been exciting, but we don't have ICD diagnoses in kids. And, excuse me, these are pre-verbal children. So you can't really do a full independent diagnostic interview. But there are Rome criteria. And what this is a way of looking at symptoms. So they're sort of like the DSM for the gut in the sense that there are a number of symptoms, exclusion criteria, you have to meet a certain threshold with a certain frequency and a certain time commitment, and then you can be fed into the algorithm and you get a diagnosis. And these are the most common diagnoses in the first few years of life, okay? So we looked at those and we asked, are the three groups different based on the mother's grouping? And this is what we initially found. Again, the dotted line is the no effect. We saw a small effect for colic, right? So an increased odds ratio at 3 months, 1 to 3 months, and we saw it at 6 months, although some clinicians would argue that you shouldn't really be diagnosing colic at 6 months. But for the constipation, you see that there's an effect that gets bigger with time. But this is comparing SSRI exposed to the controls, to the unexposed. We then asked, well, how much of this is being driven by the depression as opposed to the SSRI? So we repeated this, now comparing the SSRI group to the depressed groups, right? So the two red-colored groups. And here you see that the colic findings are completely washed away, but the constipation findings hold. And I'm going to merge these two graphs so you sort of see it very obviously. You could see that the blue in the colic is completely accounted for by depression, but it doesn't account for the constipation. And the other disorders I just included, but they were so low or low in some groups that we couldn't really do any statistical analyses at this point, and we'll have to wait for another day. So the most consistent part of my talk has really been constipation. And what we showed is, it's sort of very interesting. We took findings from animal models where manipulations of the serotonin, increased colonic transit, a marker of constipation. We then showed in a birth cohort that over the first year of life, the kids who had exposed to SSRIs had higher functional constipation as reported by the mother, so bias is possible. And then we translated it to a population study where we showed that the SSRI exposed kids had higher diagnoses by a physician or prescriptions for a laxative that continued all the way into childhood. So it's a nice model of translational epidemiology, and this is a case where they do talk to each other. And I wanted to acknowledge for a moment my dear mentor, Myrna Weissman, because this has always been her sort of conceptualization of translational epidemiology, where you don't just work in one field, but by taking findings from one discipline, trying to look at them in another, replicating them in a third, you get more insights, but you also have more opportunities to replicate, to understand clinical mechanisms, and so forth. And I wanted to give a quick shout out to our K awardee, who I share with Milena van Dijk, who is going to be giving the junior faculty grand rounds in 2 weeks, and she's talking about something different, but is going to be using the similar model of preclinical to clinical to population to talk about maternal stress and distress at various times. Okay, I have 5 minutes now. Happy 5 minutes? Okay, good. So here's the question. What can we do, right? Now, as I said in the beginning, I'm not a clinician, and it's a gross overreach to take research data like this and then apply them wholesale to clinical situations, because these are costs of hundreds of thousands, but again, it's one clinician, one mother, and a very unique set of circumstances. But what we can do is sort of look at the story from the other side and say, if a mother is on a certain line of treatments, what do we know? What are the clinical guidelines? And how do our data resonate or not resonate with those guidelines, especially as it pertains to kids? Now, one thing haven't talked about today is psychotherapy, and that's always an alternative, obviously, to antidepressant use. For mild depression, often it is recommended as the first line of treatment in depression, in pregnancy. And there are a number of studies on IPT, CBT, other forms of therapy that can be very effective in pregnancy and should be used. However, they may not work for everyone. And also in the US, they're not often covered. They're expensive. They take a lot of time. So for many reasons, psychotherapy may not be the preferred route for many mothers. So then obviously there's the pharmacotherapy option. SSRI exposure is what I've been talking about all day, well, all hour. And what we see is they are recommended, SSRIs are recommended when there's more significant or severe or comorbid depression. But even then there are ways to protect the child both within pregnancy and outside. Within the pregnancy, often if there's a lot of use in the first trimester, an additional ultrasound might be recommended. If there is third trimester use, maybe tapering is often recommended at the very end just to minimize the risks of possible antidepressant neonatal exposure. But treating the mother is always a very high priority. So what do we do? There's also I just said that. There's also a third option, right? You might want to be on an antidepressant medication, but not be on an SSRI for some reason, possibly because you're concerned about effects of prenatal exposure. Well, there are other antidepressants, and what we're working on now is studies in both Denmark and our Mayo Clinic population to look at the effects of SSRIs versus other medications. While I don't have final data, I will show you some preliminary data we got using bupropion in the Mayo Clinic network data, which is based on electronic health records. This is done with my colleague, William Bobo, who I think many of you know. And very interestingly, they looked at the effect of SSRI exposure and compared it with the alternative exposure to the bupropion during pregnancy. And then they looked at the emergence of a depressive or an anxiety disorder in the first 10 years of life. And lo and behold, they saw that the risks with bupropion were almost half, in fact, more than half lower. And that's because this is a protective effect. And it was stable after controlling for depression. Now, a friend of mine yesterday said, well, you're bearing the lead. This is your best slide. You should have shown it in the beginning. But it's so preliminary that I didn't really want to give it more than it's due, because we still have to account for the fact that the women, there's a reason likely that women are on bupropion instead of instead of an SSRI, because a lot of times, for example, bupropion is given if there's smoking or substance use during pregnancy. So it's exciting, but at the same time, it needs to be first validated and then replicated in other cohorts. So I wanted to end with a very quick smattering of what we're doing and also invite collaborations with people who might be interested. The first is what I just described, right? Outcomes of exposures to other medications and psychotherapy as comparisons. Also, what I've shown you right now has mostly been gut findings and brain findings, or psychiatric findings. I haven't really talked about how the two blend together. And as the offspring in the Sherbrooke cohort age, we're increasingly looking at that. The problem is that the gut findings emerge much earlier. So oftentimes you're having all the gut stuff ready, but the mental health problems haven't yet emerged. We also are funded to roll look at the role of maternal and infant-related microbiomes as mediator of the transmission between mom and child. And we're working with Tor Savage at Baylor University to look at serotonin-specific microbiomes. And then finally, very briefly, we're also looking at everything I've talked about in this talk has been serotonin changes or exposures or perturbation, but that raises the sister question, what about in normal development without any exposures, right? What is the role of serotonin? And this is work led by our very own Jeremy Veenstra van de Wiel and Kelly Sparks, who's here. And what they had shown previously is that in the absence of any exposure, it was the mother's serotonin in the earliest part of pregnancy, before the kid's serotonin systems came online and before the barrier developed, the blood-brain barrier. And they showed that the maternal serotonin system had a much bigger effect on gene expression than the child's equivalent. So, of course, we wanted to know, are these relevant to humans? And what they did in a subsequent study, I was not involved in it, they showed in an autism sample that the mother's whole blood serotonin levels was associated with the severity of autism symptoms in the child. But the child's own serotonin levels were not, and the dad's serotonin levels were not. So this sort of fits with the animal hypothesis. And what we're now going to be doing is, as Christine gets closer to me, is to stop. What we're now going to be doing is sort of replicating this at a more population level to see how translatable these mechanisms are. All right, I think we're just about of perfect timing. So I wanted to acknowledge, of course, the whole department, but especially 3 people who've been instrumental in my life. And without them, I think there'd be no me standing here on stage. And the first is obviously Myrna Weissman, who has just been the most incredible and phenomenal mentor one could ever ask for. And I could have spent the whole hour talking about her, but I didn't, but I could. The second is Jay Gingrich, who really pioneered a lot of the animal studies and the work that then allowed us to get the hypotheses for these future studies. And when I think about it, just about every question we've asked and every analysis we've done can find its way back to the Gingrich brain. It's really, thank you so much. And the third is Jonathan Posner, who really was instrumental in translating the population data to the biological and has just been the most incredibly wonderful colleague, even after moving to Duke. I also wanted to credit all our teams, I'm just a representative, but everyone's been doing the work, and the funding that we've been so lucky to be receiving from the NIH and a few other non-governmental agencies. And finally, I wanted to thank you for coming. It's really lovely to give grand rounds at your home institution. A little nerving, but also a lot of fun. So thank you.